I mean, with aging, there's certain things that are inevitable right now, at least in the next 50 years, so to speak. So you're born with a set number of neurons, you're born with a set number of cardiomyocyte muscles, which is the cell in the heart tissue. You're born with the same skeletal muscle fiber amount that you have as a child that you have right now. It's just you have the potential to widen that and then increase the ability of your body to systemically and locally contract that tissue. But your actual number of skeletal muscle cells is the same. And those muscle cells have something called satellite cells that accompany them, and they stimulate muscle growth. They're very important. And those kind of senesce as you age, but you can totally reverse their decline, and you can keep more, so to speak, not retired, and not that they will die too, but you can keep them living longer along with you as a person with dietary habit and muscle mass gain, essentially. So there's something, and then we have skin, we have collagen loss and elastin loss as we age. There's a thinning over the skin. But if you kind of put aesthetics aside, I'll let the dermatologist talk about that. But if you kind of put aesthetics aside, you can fortify yourself to have this incredibly protective endocrine organ your whole life. And like I said, you can be doing most of what you want to do way into life and still build muscle. I even have evidence you're still building muscle into the 90s. I think the most common, there's a few, and now that I'm an outpatient, I don't see like hip fractures as much, which was it's a huge proportion due to frailty and loss of bone mineral density, essentially. I see a lot of low back pain from arthritis and degeneration, a lot, and knees. And then I see a lot of frail older ladies that just stopped working out, maybe in their 40s, maybe in their 30s, or just never really thought that they could maintain that kind of muscle mass. They didn't think it was necessary. And then I'm treating them later on in life, and their spine is dehydrated. They have chronic arthritis. They didn't build enough of a reservoir of muscle tissue, like hypertrophied, meaning bigger muscle tissue that could act as like a protectorant and against their frailty, because bone and muscle, they tend to work together. Muscle is like a C around bone, and the load of the bone, the same loads that hypertrophy muscle and deform bone are what increase your bone mineral density and then increase your muscle mass. And so people did not load themselves enough. They didn't lift heavy. They didn't lift frequently enough. And a lot of what they're experiencing now could be avoided, especially arthritic knees, degenerative changes in the spine. And then there's a whole metabolic component that we're now discovering with arthritis, which in a few years we should have this talk again, because there'll be a lot more research showing that even things like what we thought osteoarthritis was just simply a biomechanical problem has a metabolic background from high glucose spikes and other poor dietary eating habits, which I'm sure Jill might have touched on, or our nutritionist might have touched on. So I just want to, because of what I treat now, I'm like, I can meet them where I am. I have to use a lot of tricks of the trade to work on these frail populations and kind of get them to say, you can actually lift more. We've underprescribed you for too long. You can lift more. If I could have just counteracted that, they could have saved them a lot of pain and suffering, and they would have had better function when they came to me had they been training significantly, even if they'd started in, their 40s, even if they started in their 50s or their 60s. Like, you can still make a change. When you get to me and you're 85 and 90, we're going to have a little bit of a harder time, but we can still make a change. But it's, you would have had a much easier time for yourself if you had that big reservoir of muscle. It depends how osteopenic they are, but no, it is never too late to start something. We have used to work around something that would be like high impact, but even if you're slowly lifting weights, you're not going to like break all your bones, which even I treat osteopenic individuals and osteoporotic, and we have ways to work around that with BFR and whatnot, but you're never going to it's way less safe for you not to weight train, because you'll protect yourself from falling. If you do little power motions, you can increase your balance and strength, like med ball throws and step ups and quicker motions in a guided, safe environment. If you're really that osteoporotic and frail, if you're around the age of 90, let's say, but it's much safer to have the muscle bulk on you. Muscle's it's a sponge for glucose and fatty acids. It keeps your blood sugar stable after you've had a carb heavy meal. It reduces risk of insulin resistance. It's a reservoir for amino acids. If you get sick, your body can then break down some of the amino acids in the muscle and help you through the sickness. So it's far less, it's safer to have the muscle than it is risk in the gym of dropping something. So again, you need to be like assessed by a professional, like a physical therapist, to say, okay, well, we're not going to do like crazy hard plyometrics right out the gate because you're osteoporotic. I'm not going to push on you because you're osteoporotic. You're going to put some blood pressure cuffs on you. We're going to do some loaded weight. We want to load the bones. They still respond to the load. And we have to get your diet under control, your calcium, your vitamin D, your iron, your omega-3 fatty acids, all that stuff under control. And then being tracking. So we're making sure we're putting enough reserves, then we're putting enough resources in that we're taking out. So again, it's far more like just the pros and cons. The pros of weightlifting outweigh the cons, and it's not really unsafe unless you're doing like a highly complex jumping motion. Load is actually going to help you in the case where you have brittle bone. Blood flow restriction, there's a few variances in devices, but basically it's slightly occluding on a controllable blood pressure cuff your forelimbs. So you put about deltoid level on each of your arms and then about thigh level on your legs. If you have the mobile cuffs like we do, there's a few units. And you basically pump up the pressure to occlude the venous system and allowing the arterial system to flow pretty normally. So you're slightly smushing the veins. They're more compressible. And you're denying the body a little bit of its venous return. So you are increasing, because the bone has a little inlet itself, a little hollow, like your femur bone has this little hollow tube in the center of the bone where all the vasculature is, and all the little tiny vessels that go to the other areas of the bone. And when you occlude the limb, you're also building up pressure inside the bone. It's called intramedullary pressure. And it combined with some of this fluid shear stress from loading bone, from the actual bending and loading of bone when you're working on it, stimulates osteocytes and activates a few bone building pathways without the need of a heavy load. And in fact, they've studied it like that it's best around like 20 to 30% of your one repetition maximum, the amount of load you choose to use for the exercise. So you'll do something like a 10-minute workout with like usually a rep range around 30, 15, 15, 15, like 4 sets of higher repetition with this lower load. And you'll experience like this a little bit of a burning sensation. It's not very comfortable. It's kind of an uncomfortable therapy when you're doing it. You want it to stop if you're doing it right. It's a lot. And you recreate the metabolic environment in the muscle tissue and in the bone that you would when you went out and did a heavy workout, a high sprint. You kind of trick the osteoblasts and you trick the satellite cells and you trick the growth hormone and all these things that get released with a hard workout that build muscle without actually having to overload the joint, especially if the joint is injured and I need it to heal. I just need to push fluid around and get that stimulus, and I can do it with that 20 to 30% load. I don't need and the research has shown there's no real benefit to like increasing and lifting a heavier weight with the blood flow restriction on. In fact, the low loads seem to perform better when compared in multiple trials. So it's a way for me to hypertrophy muscle. And yes, it does hypertrophy. There's several studies that show it does without overloading. There's also some interesting studies. I found like 3 of them, something called cross-talking, which is if I have a patient come in casted, immobilized on one limb, like an arm or a leg, I can BFR train the other arm.
Yep.
You can squeeze it enough and train the other arm so that the immobilized limb doesn't necessarily hypertrophy, because it's got to actually move too, but it will maintain the muscle mass the time it is in the cast if you train the other arm, which is like mind-blowing and shows some systemic effect of the blood flow restriction that we don't quite completely understand yet. But it's awesome, because then that's half the problem with immobilizing tissue. Within, I'd say 10 days, even less, I think it's like 4 days, you destroy a lot of tissue, you lose strength, and then you start losing, the tissue starts atrophying like crazy within 10 days. And so if I can prevent just the if I can just keep the muscle mass that's there in the immobilized limb by cuffing the good arm, I mean, that's incredible. And that's like a 10-minute treatment. And then I can do, again, just 20 to 30% load, and I can help a patient recover faster once they come out of the limb. That's like mind blowing.